surgeon at the Hospital for Special Surgery, and I welcome you here tonight at the Renaissance and allowing us to give this talk here. The title of my talk is Domo, Arigato, Mr. Roboto. I'm going to talk about knee arthritis in 2012. Does anybody know what Domo, Arigato, Mr. Roboto means? It means thank you very much, Mr. Robot. It alludes to a song from the 80s from Stitz, and I think you'll appreciate why I'm thanking the robot by the end of the talk. So these are my disclosures. I am currently on the scientific advisory board for a company named Bluebell. They do robotic technology. I'm not going to be talking about any of their technology. They're kind of a startup company. I'm a consultant for Pipeline, who does some implant design. None of the things that I'm talking about today are related to any of the companies that I work for. So apart from doing knee surgery, I also had the honor and privilege to work with the best baseball team in New York, the Mets. And we've had our ups and downs over the past couple of years. Since I worked with them, they were heading away from going to the World Series. And on your left is Andy Chavez catching the ball that we thought would bring us a trip to the World Series, and then that's Carlos Beltran striking out in 2006, ending our dreams at the time. And it's great to work with professional athletes. This is my daughter with Mr. and Mrs. Met, as well as baby Met, and it's been a lot of fun. Even through bad times, as we've had over the past couple of years, you have these kind of magical moments. And this is Johan Santana pitching his no-hitter 26 days ago, and me with him in the clubhouse a couple minutes after the no-hitter. This is Mike Baxter from Queens, who caught the ball to save the no-hitter. So you have these magical moments. But you get to work with these athletes who have beautiful knees. And this is Mr. Met, and this is what he looks like today. You can see how nice and straight his knees are. And a lot of athletes have nice straight knees like this. But over time, athletes get injured, and we all get injured. And you go from a situation where you have these beautiful, pristine knees that are nice and straight to a situation that many of you may have here in this room, and that's a situation where you start to develop knee arthritis. And so this is Mr. Met, maybe in the future, with some arthritis of his right knee. You can see that he's got some bowing of the knee, some deformity of the leg. And over time, that bowing can get worse, and this is really what happens with arthritis. The knee can collapse, and I'll talk about that in a moment. But the point here is that over time, even very healthy knees can undergo this degenerative process and develop this collapse, which again, many of you may have in this room. So what is knee arthritis? Well, arthritis refers to wear and tear of the joint. I'm going to be talking today about osteoarthritis, not rheumatoid arthritis. Osteoarthritis tends to be a degenerative process where a portion of the joint wears out. So on your left is the healthy joint, and on the right is the arthritic joint. And what you notice is that there's a change in the shape of the bone, as well as a collapse of the two bones on one another. So let's see if my mouse works. So in the healthy joint, this is the femur bone or the thigh bone. This is the tibia or the lower leg bone. And there ought to be a nice space between the bones. Also, the bones should look rounded and curved. Over time, with the arthritic process, you see that the bones actually change shape. They become much more squared. They are no longer what we call congruent, or they no longer fit together. And there's an obliteration of the joint space. So you get this bone-on-bone situation. This is, again, the long leg alignment film of Mr. Met. And you see that on his right knee, he's absolutely bone-on-bone on the inside part of the knee. And he's developed this bow-legged deformity that I'll talk about in a couple slides. But what I want to emphasize is that it's not just a wearing away of the cartilage or the padding of the joint. I can't tell you how many times people come into my office and they say, well, why can't you just inject something into the knee? And the point is, we can't just inject cartilage because the entire architecture of the joint has changed. In many cases, it's a collapse of one part of the joint. But the point is that it's not just the cartilage, it's also the bone. I'll often use the analogy that the knee has two compartments, and it's like you have two wheels on either side of the knee, one on the inside and one on the outside. And in a lot of cases, you have a flat tire in one compartment. So if you look here, there's a flat tire on the inside part of the knee, and this inside part of the knee is bone on bone. If you think about the air of the tire being the cartilage, it's not just that you've lost air in that compartment, but you've also dented the rim. So you can't just inject cartilage in there. You actually have to do something that changes the shape of the bone. So keep that in mind. Arthritis is a big problem, an enormous problem. It's been estimated that up to about 20% of us are going to develop arthritis in our knees over the course of our lifetime. This is some data from the NIH looking at this. The estimates are anywhere from 1 in 10, again, to 1 in 5 of us will get knee arthritis. So this happens to many, many of us in the community. I almost think it's part of the human condition, really. And it's a tremendous burden to society. This is the number of total knees that we're going to do in it's projected out into 2020 and 2030. And these are serious numbers. We did about 700,000 total knees in the U.S. in 2007. It's estimated that we're going to do 1.5 million in 2020 and 3.5 million in 2030. So those are just numbers, but if you think about the cost of this, the cost of total joint replacement in 2030 is going to be about 1% of our gross domestic product. 1 cent out of every dollar is going to be spent on total joint replacements in 2030 in this country, and the vast majority of that is going to be on total knee replacement. So it's huge numbers, it's huge cost, huge burden to society. Just a word about the history of arthritis and our treatment for it. Arthritis, of course, has been around for a long time. It seems to be increasing. It's probably because of our dietary habits. May also be because of our sporting participation and that we're living longer, but it's always been around. We didn't have surgical treatments really until the 1970s. We used to fuse joints before that. We would fuse knees. That's still practiced very rarely, but just to give you some context of this. It was in the 70s that we developed a modern-day total knee replacement, and it was really developed at my hospital, the Hospital for Special Surgery, in the early and mid-70s. And these are the godfathers of knee replacement. John Insall, who worked at HSS and then broke off. He unfortunately is no longer with us. Chip Ranawat, who actually is still operating in special surgery. And Peter Walker, who's a scientist who's affiliated with joint disease in Midtown, and he's still doing research at a VA on joint disease. But these three, Insall, Ranawat, and Walker, really developed the modern-day total knee replacement in the 70s. And this is what it looks like, the total condylar prosthesis, which was introduced in 1974. It's the basis of all modern-day knee replacements. And really, you'll see lots of marketing about knee replacements. They're all based on this design. They're all just small variations of this design. There's nothing really that's changed in the basic knee replacement design in the past 40, 50 years. And the design has been lasting because it solved two problems. What we were trying to accomplish in the 70s is we were trying to take away pain and get people to walk again. We weren't trying to get people on the golf course. We weren't trying to get people running. We weren't trying to get people hiking Kilimanjaro. We wanted people just to be able to walk. And the problems we had when we started in the 70s with this were fixation and wear. We couldn't get these things to last more than 5 or 10 years because we couldn't glue them to the bone very well. And the plastics that we used would wear out. So a whole generation of orthopedic surgeons were focused on these basic issues. Can we develop materials that wouldn't fall apart over time? And can we get these implants to stick to the bone so that they wouldn't wear out after 5 or 10 years? And in 2012, we really solved those initial problems. We now have excellent long-term survivorship. About 95% of total knees will last 10 years, and about 80% will last 20 years. About 60% is now they will last 30 years. So they last a long time. Again, that was the original goal of our godfathers of knee replacement. They weren't trying to get the knee to move like a normal knee. They wanted it to last a long time. It will predictably relieve pain and it corrects deformity. However, there are issues with knee replacement. And I'm going to stop here just for a second and issue a bit of a disclaimer. I do a lot of knee replacements, and it's a wonderful operation. It is one of the game changers of last century. There was a editorial saying total hip replacement was the surgery of the century for the 20th century, and total knee replacement was actually right behind it. It is a miraculous operation in a lot of ways. And so I'm going to talk a lot about alternatives to knee replacement, but I do a lot of knee replacements. I think it's a great operation. I think that 10, 20 years from now, we shouldn't accept the results that we have today. We should strive to do better. And some of the things I'm going to talk about are ways that we can do better, but I don't want to bash total knee replacements. I do want to bring up some of the limits of knee replacements. So, total knee replacement is a great operation. However, it has its limits. On your left, you see how a normal knee moves. So a normal knee has these cruciate ligaments, the ACL and the PCL, and these ligaments really define the kinematics of the knee, or the way the knee moves. When we do a knee replacement, we cut out these ligaments, and we replace them with this knob or post, which is just a plastic post, which basically controls the way the knee moves. But in doing so, we fundamentally change the kinematics of the knee, or the way the knee moves. So what does that do to the knee? Well, this is a normal knee bending. This is the outside part of the knee. This is the inside part of the knee. And this is the way a total knee moves. Again, this is the outside part of the knee, and this is the inside part of the knee. So it looks similar, but if you can see on the outside part of the knee, the knee's kind of moving a little bit in the wrong direction compared to a total knee, or excuse me, compared to a normal knee. So the knee kinematics are fundamentally changed when you have a knee replacement, and that's in large part by the design of the knee replacement. It's not necessarily a bad thing. It's created a durable solution, but it does create a knee that moves differently from a normal knee. It creates a knee that's not necessarily an athletic knee, and it does create some problems, and I'm going to highlight them in this slide. So if you look at knee replacement, about 20% of people who have a knee replacement actually wouldn't do the operation again. Said another way, 80% love their total knee. But there's a small percent, 1 in 5, who actually don't like their total knee. And why don't they like their total knee? Well, that question's a little bit elusive, but here are some of the reasons why they might not love their total knee. Obviously, if you have a complication, that's a reason not to like it. If you have pain that you didn't expect, that's a reason not to like it. But a lot of people don't go back to the things that they thought that they would go back to. And in fact, if you look at return to sports, for example, only 64% of patients return to the level of sports that they had before their knee replacement. So somebody says, I want my knee replacement because I want to play more tennis or more golf. You can't guarantee that you're going to play more sports after their knee replacement compared to before. And that's in contradistinction to a hip replacement, where in general people do more sports after their hip replacement compared to before. Now there are plenty of exceptions. I live right around here. I play tennis around here, and I lost last year in a doubles match to a guy who had both his knees replaced, and I'm not a bad tennis player. So people can do amazing things on knee replacements. But if you look at averages, on average people do a little less sports after their knee compared to before. And a common thing people will talk about is golf. People tend to feel better playing golf, but if you actually look at what people do, about 30% of people will walk the golf course before their knee replacement, whereas only 15% will walk it after their knee replacement. So you can say that total knee replacement is a great operation for pain, but it's not a sports operation. And patients on average can expect to do less sports after their total knee compared to before. Again, there are plenty of exceptions. So the question is, can we do better? We're going to spend 1% of our gross domestic product or so on this operation. Can we do better? And I would submit that we're living in an age now of customization. When my daughter wants to get a teddy bear, I can't just get her an over-the-counter teddy bear. I have to go to the White Plains Mall and buy her a Build-A-Bear and customize what kind of fur and what smell the bear is and what noise it makes when you squeeze its paw. If I want to go for a run and listen to music, I don't just listen to the radio anymore. I listen to my playlist, which has been customized to my run. You can customize your Nikes. This was an article from the Times last year where you can even customize your prosthesis now. You can actually print out in 3D a prosthesis for amputees. So an amputee may have a prosthesis that they wear to the lake, one that they wear to work, one that they wear to a formal party. So you can really customize things in different ways. So the question is, can we customize knee surgery to make it better? And really the focus of my talk today is on robotic partial knee replacement. And I'll touch on partial knee replacement in a second. But the point I want to make is that we're really now in an age where we can not just have a couple knees, we make the same cuts on everybody and put in these standard total knees, but we can really refine our surgical procedures so that we customize it for an individual's need. And I'll show you how we do it. But before I do that, I want to talk a little bit about partial knee replacement. I talked about total knee replacement. I think it's a wonderful operation. I think in some people it's got some limits. Partial knee replacement, which is also known as unicondylar knee replacement, and I'm going to also refer to it as robotic knee resurfacing. It's all the same procedure, different terms for it, is an operation that's been around for a long, long time. In the 70s, it was not clear what was a better operation, a total knee replacement or a partial knee replacement, and the answer in the 70s was total knee replacement. Why? Because the materials were not very good. And they weren't good enough, really, for a partial knee replacement. As the materials and the fixation have evolved, partial knee replacements have had a tremendous resurgence. However, there's a whole generation of doctors who never did a partial knee replacement. Or if they did a couple, and they'll quote you numbers from the 70s, which is very unfair. When we talk about total knee replacement, we never talk about data from the 70s. We talk about data from the last 10 years. But some surgeons will still talk about data from the 70s for partial knee replacements, and they'll say, well, they only last 3 or 5 years. In 1972, 1974, that was true, but that's 40 years ago, and the materials have changed a lot, as has the surgical procedure. The partial knee replacement now has been around and practiced for about 30 years. We have excellent 10 and 20-year data. I showed that I mentioned that total knees have about a 95% chance of lasting 10 years. Partial knee replacements have a 90% chance of lasting 10 years. So about a 5% difference. At 20 years, it's not as clear with partial knee replacements. They last anywhere from 40 to 90% of the time, 20 years, depending on what study you're reading. Why would you consider it? I get asked all the time, why just do a partial knee replacement when you can replace the whole thing? Well, you may want to keep some of your knee. In particular, you may want to keep your ligaments, your ACL and your PCL, because when you do that, the partial knee replacement will move very much like a normal knee. And if you look at what the ramifications of that are, not only is it bone sparing and minimally invasive, it can be done as an ambulatory surgery, but perhaps more importantly, people can go back to sports. In fact, 96% of patients will return to their preoperative level of sports, or they'll exceed their preoperative level of sports. 90% in another study maintained or improved sporting activities. So a partial knee replacement is in a way like a total hip replacement. People tend to do as much or more sports after their partial knee replacement compared to before. However, it's technically quite challenging to do. And if you don't do partial knee replacements, if a surgeon doesn't do them, he shouldn't do them. They're really hard to do. There's been a number of studies now from Europe that have shown much higher failure rates, 6 or 7 times higher failure rates in surgeons who do less than 20 partial knees a year. It is very technically demanding, and surgeon experience is kind of everything for partial knee replacements. So it's an important point. I'm going to take you through a case, and I'm going to highlight this robotic technique that we've been using. The robotic technique, we've had special surgery for 5 years, going on 6 years. I've been using it the entire time. I was the first one in the New York area to use this technique. I think the third person in the country. Now do hundreds, up to 200 of these a year. So I do a lot of these, and we do a lot of them in special surgery. And I'm going to show you how we do it and how we customize the surgery there. So this is an example of a gentleman who actually had a partial knee replacement on his left knee and came in with pain on his right knee. He did not have a significant deformity, bowing, but it was there. It was about 5 degrees. Certainly you can do it with much bigger deformities. And you can see that he's really collapsed on the inside part of the knee. So again, if you think of 2 tires, he's got air on the outside tire, but no air on the inside tire. And this inside part of the knee is collapsed. So this is what we do. We get a CAT scan, and this is how the robotic technique works. We get a CAT scan preoperatively. On that CAT scan, we can make a 3D model of the knee. I then take that 3D model in the operating room. I know you guys are eating, so there's no blood or guts here. But I'll show you the computer screen and actually how we do the operation on a computer screen 10 or 20 times before we ever touch your skin. So what I'm doing here is looking at the CAT scan of the patient's knee, and I'm choosing the appropriate size for the implant. There are lots of different sizes. I'm choosing, importantly, the appropriate position for the implant. And I can use numbers that help us define what the position is. I can use visualization, and I can see how the implant's going to fit in the bone. I can see things like cysts that we can work around. And I can really customize how we want to put the implant into the bone in a very precise way. And importantly, I can look at how the implants are going to fit together, which is one of the real key issues in partial knee replacements. Do they line up together? So I can look at it in 3D, I can look at it from many angles. And what I'm doing here is I'm doing the surgery virtually before I ever touch the skin. So I'm making all sorts of small adjustments to the implant position until I find the sweet spot, if you will, where the implants fit just right and they fit vis-a-vis one another just right. So this is actually, I think, the most impactful aspect of the technology. You can do the surgery virtually before you touch the skin. No more trial and error. Once you've got the implant lined up, you program that plan into a robotic arm. The robotic arm, I don't have a picture of, but it's attached to this small burr. It almost looks like a dental burr. And this burr then comes in through an incision that I make. I control the burr at all times, but the burr doesn't allow me to remove bone that I don't want to remove. In this case, it's showing how you could resurface all different parts of the knee. Usually I just resurface one part of the knee, but the point here is that you get a very machined, controlled sculpting of the bone, and that allows you to put the implants exactly where you plan to put them on the computer screen. So again, it removes a lot of the guesswork. It makes the surgery very reproducible, and importantly, it allows us to plan in such a way so that we get the natural motion of the knee restored. So this is a before and after picture. This is what the knee looked like before the surgery. This is what it looked like after. And even if you are not used to looking at a lot of x-rays, you can see that these implants line up very, very well on one another. Again, if you use an analogy of the flat tire, here you've got a flat tire, and here you've put air back in the tire. What you've got on this side is cobalt chrome, plastic or polyethylene, and then titanium. And these are the same materials that we use in a total knee replacement. But importantly, again, you're preserving what's in this region, which is your cruciate ligaments, your ACL and your PCL, and you're preserving the rest of the knee. So this knee should move very much like a normal knee. I was the first to publish on this technique. These were the first 7 cases that we did more than 5 years ago now. We've done about 500 cases. We've had very good results. Our failure rate is about 1%, which is very low. Most of those failures, there were only a handful, were very early on when we were working with the technology and understanding the technology. It's a very durable procedure, and our results, again, have been excellent. We've done all sorts of research. I have a computer-assisted surgery lab at Hospital for Special Surgery. We've looked at how straight we get the legs after the surgery and how well we can control our correction. We've looked at accuracy studies, so I've shown in my lab that on cadavers we're 3 times more accurate using the robot versus manual trial and error techniques. And so the question is, why do we customize knee surgery? The concept here is that we're trying to restore the kinematics with robotic unicondylar knee replacement and preserve the natural motion of the knee. But on a bigger level, we're trying to control the operation. One of the kind of dark secrets of orthopedics is a lot of orthopedic failure is not the patient's fault, but the surgeon's fault. We're only human. We're trying to do the best we can. We're not perfect, but with these tools, we can get a lot better. And I think we can really create a much more reliable operation for patients if we use these tools. Do you need a robot to get an excellent partial knee replacement? No, but it sure does help, and it makes sure that we don't have as many failures as we did in the past. So in summary, Domo Arigato, Mr. Roboto. Thank you very much, Mr. Robot. I think robotic unicondylar knee replacement allows for us to customize implant position. It allows for durable, long-lasting pain relief, and allows us to normalize knee kinematics. And some of the things that I didn't talk about or get into in this talk, but I would love to talk about in the Q&A session, is how different this operation is from a knee replacement. We have a patient here who underwent knee replacements and did very well with them. And that's fantastic. You can do beautifully with a knee replacement. With partial knee replacement, this is what I want for patients. I want patients to be back to work in 2 weeks. Usually they use a cane for a week and a half or 2 weeks, but I want people back to work in 2 weeks, or at least back to their life in 2 weeks. I want them to return to all their sports, and I don't want any complications. So this is an important issue that we can talk about in the discussion, but there is, if you look at the risk of complications from a total knee replacement versus a partial knee replacement, total knee replacement has 3 times the risk of complications of a partial knee replacement. And the complications range from infection to knee stiffness to medical complications such as heart attacks or pneumonia. So the complication profile is much less for a partial knee replacement, which of course is a critical thing. No matter how long that knee lasts, if you have a complication, you're probably not going to be very happy. And the last thing I just want to touch on is from a 1,000-mile view in terms of the socioeconomic ramifications of evolving this procedure. If you can get people back to work in 2 weeks, if you can avoid a rehab center like a Berg or inpatient rehab, if you can get patients out of the hospital after a night or 2, if you can avoid all the pain medicine that people need with a total knee replacement, imagine the cost savings, not only for the patient and their family, but for society, if you can really bend this curve of how people respond to a knee replacement. So that's a bigger issue. We're actually doing a large-scale study looking at these issues, which we hope to finish within the year. So our goal is not just to correct deformity and to relieve pain. We think that we can do that very predictably, but we want to get people back very quickly doing all the things that they love to do, and all the things that they love to do with us and make us so happy. So I thank you for your time, and I certainly welcome your questions.
Do you redo total knee replacements?
I do revision total knee replacements.
And what is the success rate on the total knee replacement?
The revision total knee replacement?
Yes.
So there are lots of different reasons for revision total knee replacements. but on average, they tend not to last as long as a primary total knee replacement. So the 10-year survivorship for a total knee replacement, a primary, is 95%. It drops down to between 60 and 70% for a revision. So the durability of a revision is not as good as the durability of a primary total knee replacement. Now there are lots of different ways to characterize success, right? You can have a knee that lasts 30 years, and so the surgeon may say that that's a success. However, if you've got pain with that total knee replacement and you're not able to do the things that you want to do, it may not be successful from a patient's perspective. And one of the points I was trying to make is that our forefathers on total knee replacement were defining success by how long these things last. They weren't necessarily defining success by how happy patients were. And there's a difference. So we can get things to last. A fusion will last forever, but you can't do much on a fusion. So is it a successful operation to have something that lasts forever, but you're not that happy on? It's kind of a philosophical discussion, but one of the problems, I think, with total knee replacement is our definition of successful total knee replacement may not reflect what the patient's expectations and wishes are. So a surgeon may tell you this thing's going to last a long time, end of story. But you say, hey, I need to get back to work or else I'm going to lose my job, or what I really want to get out of this is I want to go back to playing tennis, or I want to go back to playing golf. And so the patient's thinking something, with the surgeon's thinking, I'm not going to have to do another operation for 30 years, and I don't care what the patient's doing, I'm going to be happy. So success is a little bit slippery, and I think we have to be very clear with how we define success after these operations.
Let's take a worst case scenario. Suppose this doesn't work. You still have the option of a total knee replacement?
Yeah, so the question is, what happens if partial knee replacement doesn't work? In 2012, the treatment for a failed partial is a total knee replacement. A lot of people will say, well, can't you do another partial knee replacement? Or can't you patch another part of the knee? That's been tried.
But you can do it. That's
You
what I'm
can certainly
saying.
do a total knee replacement, and it's akin to a primary total knee replacement. If you ask me what I would rather have, would I rather have a primary total knee replacement or a total knee replacement after a partial? I'd like to have a primary total knee replacement in a virgin knee. That's always the best total knee that you're going to get. However, I'd much rather live 20 years on a partial knee replacement and then have the option of getting a total knee replacement, kind of a new total knee, than living 20 years on a total knee replacement and then getting, a revision total knee, or having to live with a total knee that's 20 years old that's not doing so well.
That's what I assumed. Thank you.
So,
I think you said that PT was not necessary after this.
inpatient therapy, so going to a rehab facility like Pearle, where you live there for a couple of weeks, is not necessary. At special surgery, 50% of our patients who have a total knee replacement will go to inpatient therapy afterwards. So they'll spend a week or two at a therapy center. Very small percentage of partial knee replacements will go, maybe 1 or 2% will go. And only but people will do physical therapy at a local gym with a therapist. With partial knee replacements, I usually recommend 6 weeks of physical therapy with a therapist. With total knee replacements, I recommend 3 months. With total knee replacements, what I tell patients is what you put into your total knee is what you get out of it. If you don't do the therapy, you're going to be very unhappy with a total knee. I don't say that to partial knee patients. I think if you have a partial knee replacement and you don't do much therapy, you're actually still going to be pretty happy. I don't say that out loud too often, but there are plenty of my patients who just go back to life and they don't do much therapy and they do awfully well as well.
Also, is this covered by Medicare?
It is.
I'm undergoing treatment now on my right knee with steroids and hyaluronic acid, also Visc. Can I do that indefinitely, every 3 months?
So the question is, how long can you do injections?
Yeah.
I don't advocate steroid injections more than twice a year. And I don't like to do steroid injections every year, twice a year. I think that it does have deleterious effects on the joint, particularly the cartilage. You certainly increase the risk of infection if you're getting steroid injections every 6 months. The hyaluronic acid, there are a whole bunch of them, Supart, Synvisc, Orthovisc, Reflexa, they're all about the same in my mind. I think you can do those indefinitely. I don't think there's much deleterious effect of doing them. In general, most injections tend to be diminishing returns. You get the most bang for the buck the first or second time you do them, and then they tend to stop working. Not sure why, but they tend to not work as effectively over time. There's a question back here. Yeah.
From a consumer standpoint, this is probably an impossible question to answer, but generalized, based upon everyone's different person-to-person insurance differences. What is the different cost between a full knee replacement versus a PKR or UKR versus a MAKOplasty?
Well, the cost of a partial knee replacement is substantially less than a total knee replacement. There's been a number of studies on this. We're doing the biggest study on this right now, so I'll have an answer for you in a year with actual real data. But in Canada, the out-of-pocket expense for a total knee replacement is somewhere on the order of $7,000 to $10,000. This is in the Canadian system where everything's covered. And the reason is because you have time off of work, you're spending co-pays on doctor's visits, you're traveling, you're going to your therapy center, you're buying pain pills. So even in a system like Canada, you wind up spending $7,000 or so out of pocket for a total knee replacement. Our hypothesis for our study is that the cost for partial are about a third of that. A lot of it is because you're not missing time from work, but a lot of it is because you're much more productive early on. I mean, think about a total knee replacement. If you have to do 3 months of physical therapy and somebody has to drive you to therapy, I mean, there's a lot of downtime. There are a lot of things that actually add up with the total knee replacement. So our hypothesis is that the cost is going to be a third. I hope to have those numbers again in a year, but I can quote you numbers for total knee replacement in Canada where everything's covered. You're still spending $7,000 out of pocket when all said and done. Yeah.
When do you know it's time to do it?
So the question is, when do you know when it's time to do it? It's a very personal question. I think the timing is a little different for partial versus total. I always tell patients that this is elective surgery. It's not heart surgery, it's not brain surgery, it's not cancer. You can do it on your time frame. That being said, there was a recent study at our academy actually this past year, and it looked at patients who had knee arthritis and divided patients into a group where you had knee arthritis and was treated with a knee resurfacing, either knee replacement or partial knee replacement, versus patients who had knee arthritis and they didn't do anything. The patients who had the knee surgery lived longer than the patients who didn't do anything. So you can live with knee arthritis and you can accommodate it, but it tends to start closing your life down quite a bit. With knee replacement, I always tell people, you'll know when you need knee replacement. I want you to come in and say, I want this tomorrow. With partial knee replacement, I tend to tell people, your spouse will know, or your friends will know when you need partial knee replacement because you're starting to cut back on life. You're still able to kind of tolerate things, but you're not going out to dinner, and you're not going on the trips, and you're not hiking, and you're not doing the things that you like to do. You may not perceive that you're changing, but your friends notice that you're starting to drop things out. It may not get to that crisis level where you come in and say, I want it tomorrow, but your friends are saying, you're not as much fun to be around. So I know that's kind of a vague way to answer it. Some more definitive things, If you're having night pain, if you're not able to walk to get exercise, you should go see your orthopedic surgeon.
If you weren't having partial knee replacement for surgery, how many visits beforehand do you usually require?
Usually it's at least one visit to talk about it, and then you can have the surgery. But in reality, usually if somebody's considering partial knee replacement, they talk to their internist, they talk to one surgeon, they talk to another surgeon, they wind up with a whole bunch of visits. I don't have a problem with somebody who's kind of geared up for the operation coming in and seeing me, and we talk about the actual procedure, and then go to the surgery. But I certainly don't have a problem seeing somebody who's just encountering arthritis and kind of walking them through injections and all the different options and waiting a couple of years and getting to know the patient. And, both scenarios happen, so there's not an absolute requisite number of visits. I would say that knee surgery in general is not something that you just say, you wake up one day and you say, I'm going to go do it tomorrow, and you don't talk to anybody. You have to, it is a situation where you're going to have to take some time to yourself to get better. So you have to carve out time in your lifetime to go this. With a partial knee replacement, you have to carve out 2 weeks. With a total knee replacement, you have to carve out anywhere from 6 weeks to 3 months, where it's your time, you're focused on your knee, you can't be taking care of somebody else, you can't have responsibilities at work, you have to have that time just to focus on your knee.
How about kneeling?
So,
Do you ever get down to the garden
yeah.
again?
I mean, kneeling is a very interesting question. So the question is, can you kneel again after knee replacement or partial knee replacement? Kneeling is one of the big problems with knee replacement. It's particularly a problem in Muslim societies and Asian societies where they can't kneel to pray. In a lot of Asian societies, they spend a lot of time in a hyperflex position. In Western societies, we tend not to squat as much. So it is hard to kneel with a total knee replacement. If you look at my fingers, they go back this far. That's how far my muscles can take them back. But I can then bend them back further. Just like my knee. My knee bends this far, but I can take my knee and bring my heel to my butt. I'm really kind of dislocating my finger and dislocating my knee when I do that. A knee replacement's not designed to dislocate like that. A knee replacement's just designed to go as far as your muscle can go. A partial knee replacement, you can go as far as you want. So partial knee replacements will allow you to bring your heel to your butt if you want. Not everybody gets there, but there aren't those limitations in the design of the implant. So people do have trouble kneeling and squatting and gardening with knee replacement. It's one of the limitations that people don't necessarily expect when they go through a knee replacement. It's a good point. It's not what our Godfathers really designed the things to do. They were designed to walk, and they're great at letting you do that, at walk, at hike, but they're not designed to squat and kneel. Incidentally, for a partial knee replacement, people are not comfortable doing it for 6 months to a year because they don't like kneeling on the incision, although that comes with time. And again, some knee replacement patients are surprising in what they can do. Just a further comment on that, you will see some direct-to-patient marketing about high flex knees, knees that are designed to flex more, prosthetic knees that are designed to flex more. There's never been a study that shows that they actually do. That's part of the marketing angle that a lot of implant companies will take. Let's go here.
Are there any situations where the partial replacement would not be appropriate, say depending on the seriousness of the arthritis?
So the question is, what percentage of patients are candidates for partial knee replacement? And it's an important question that I didn't address in the talk. The numbers vary. If you use the most rigid indications from about 20 years ago, only 1 to 5% of patients are candidates. Those indications are truly outdated, and they were devised by somebody who never did partial knee replacements, but they're still quoted. More realistic numbers are about 20 to 40% of people with knee arthritis are candidates for partial knee replacement. And I think it's actually going to inch up a little bit more. But not everybody's a candidate. To be sure, not everybody's a candidate. And probably less than half of people are candidates for partial knee replacement. So it's a very, very important thing to talk about. But because it's not everybody doesn't mean that we shouldn't consider it when we're looking at knee arthritis.
What are some of the criteria that would rule one out?
So partial knee replacement is really best used when a part of the knee is involved in the arthritic portion. So there are plenty of arthritic processes where the entire knee is involved. For example, every patient with rheumatoid arthritis has systemic involvement or global involvement of the joint, and partial knee replacement is not indicated in that sort of situation. If you're not able to bend your knee very well, a total knee replacement is probably better because you can take a lot more bone and allow some space to bend. So there are different reasons why partial may or may not be appropriate.
You have something comparable to this for hips? Because I'm looking at some possibility of revisions. I have two total hip replacements.
Yeah.
They're both 20 years old. So I'm looking at possibility of revision. Do they use anything like robotics for revisions?
First of all, I'm not a hip guy, so I can tell you.
Is there a hip guy?
There's a hip guy in special surgery. There's a couple guys there. And I can give you some names afterwards to be sure. The robot is being used for hips. It's not really designed for revision, total hips at this point. So the revision setting is a little bit more complicated. Robotics are being used for primary hip replacement. To be honest, I don't think it's as impactful for primary hip replacements. I think that the reason the robot is very useful in partial knee replacements is because that operation is hard to do by hand. Total hip replacement is actually very well performed by hand, as is total knee replacement. You don't necessarily need a robot because you're kind of cutting off the ends of both bones and you're putting together pieces that almost fit together like Lego pieces. But if you're working within one part of the knee and you're trying to get the whole knee to move a certain way, you're only resurfacing one part of it, it's hard to do that well. And in fact, it was very, very common for surgeons to say this to patients if they were before the robot. Well, we're going to try a partial knee replacement, but if the damage is too extensive, we're going to do a total knee replacement. And what they were really saying is, I'm going to try and put in a partial knee replacement, but if I foul it up, I'm going to convert it to a total knee replacement. And I was in on a lot of those cases. It happened a lot. So technology can help, and it can enable difficult operations, but you don't always need technology to get a good result. So I personally, my mother had total hip replacement. I didn't seek out somebody who was doing robotic total hip replacement. I sent her to somebody who I trusted. If I or my wife or my father needed a partial knee replacement, I actually would seek out somebody who was using the robot. I think it's that important for that particular operation. If that helps. So I work at HSS in the city, and I also see patients at Burke in White Plains. So I see patients every Wednesday at Burke, at least 3 out of 4 Wednesdays a month.
So someone can call Burke and get an appointment with you?
You actually have to call.
They have to be an inpatient.
No, you can see me as an outpatient there. They actually have an outpatient facility. But you call my regular office number and they make the appointment for you. If you call Burke, they don't really control the outpatient appointments. So I do it all through my office in the city, and there are cards that have my number. Thank you all for coming. Pleasure. Actually, one final slide. If you want more information, I have a website that's got a lot of the stuff that I went through. Some of the cards that I gave you on the back, it's got my website, and it's got all of my thoughts on this stuff. In fact, if you go to andrewpearle.com/robotic, it's got a page dedicated to the robotic stuff, including this is what the robot actually looks like. It's got an educational video, as well as frequently asked questions and risks. And then if you click under procedures, you can look at shoulder procedures, knee procedures, total knee replacement, and learn a lot more. But a lot of the things that I discussed here are on that website, and you can feel free to look at that or share that with your friends.